Okay, well, so we're just getting towards the top of the hour. I'm just going to take this opportunity to briefly mention to all those people who are already on the call that Annie Antar is here and can tell us briefly about her study. I'm actually posting in the chat some information from Annie about how to enroll patients, but I'll let her just briefly introduce that.
Thank you so much. I'm just putting up a little slide too, but just want to take 1 second. I think a lot of us who see patients in the Bartlett Clinic have had patients test positive for SARS-CoV-2 during the Omicron wave. And if not, you might have some patients in the next couple of weeks who test positive. I just want to encourage you to think about our study of COVID recovery. We are enrolling anyone living with HIV who has had a SARS-CoV-2 diagnosis. It can be asymptomatic, it can be vaccinated or unvaccinated. Any severity, hospitalized, asymptomatic, mild, and it offers $100 in compensation. It can be done entirely from home. And it does involve 2 blood draws, but the phlebotomist will come to the patient's house or to another patient of their, or to another location of their choosing. So there's a couple ways to contact them. You can either have the patient contact the study, and you can see kind of the links below. There's a website, a phone, and an email. Or if the patient agrees to be contacted by us and you document just a sentence that says that in the chart, then you can email me in a secure email their information and we will reach out directly to them. So, and we offer this in English and Spanish fully. So thanks so much for thinking about us.
Great, thank you.
And Jean Keller asked whether it was okay if the patient is pregnant.
Yes, it is. I have to look. I don't think that's an exclusion criteria, but I'm pretty sure they can. So yes.
Great, and thanks, Annie. And that information that she just had shared is also in the chat. And then very briefly, I just want to mention that we are using the Teams, and Joyce and Yuka have been putting really useful information about how to access COVID therapeutics in the Teams channel. So if anyone needs access to that or doesn't know how to navigate to that, please let me know. Joyce, anything else you wanted to mention about that?
Yeah, I just want to say, obviously treatment is very limited, unfortunately, but we're using Teams because it can be a central repository for these frequent updates. Look at your emails as well. If anybody has questions or concerns about any clinical COVID related issues, Bartlett related issues, please reach out to me. Please reach out to Yuka. I haven't been hearing much from people, so I'm assuming, people know what to do, but I know that this is a really difficult time. So just want to make sure that everybody is feeling as comfortable as possible. The other thing I want to mention is that for those of you, if you get pulled into, inpatient staff and you need extra help with covering outpatients, covering sessions, whatever, those of us who do outpatient care but are not credentialed for inpatient and haven't done inpatient for a long time, we want to help. We know most of the burden is on the inpatient team. So also reach out if you know somebody else is being pulled and they have clinic responsibilities, please reach out to me because we would like to, support you and the hospital and patients as much as possible.
Okay, thanks so much, Joyce. And now I think we'll get started with this, which is the first session of the HIV care of the clinical care of the patient living with HIV and hepatitis session. And we're so fortunate to have Dr. Tom Quinn here to give us an update on the global state of HIV. I think that Dr. Quinn is one of those people who you end up taking for granted. And I recently read an interview he did about his that he had done as part of an NIH project tracking the beginning of the HIV epidemic, and just the scope of what he's done for people living with HIV is just really hard to comprehend. So we're very fortunate to have you, and I'll turn the whole show over to you, Dr. Quinn.
Thanks very much, Eileen. I'm going to hit my slides up if this all works. Okay, can you hear me and see the slides fine?
Yes, everything looks great.
Great. Super. Thanks very much for inviting me, and Happy New Year to everyone. I was invited to give this talk about the global state of HIV, and I added to the end of it 40 years and counting. And if you check your emails, I sent along a reprint of a paper that I wrote last year, because last year was the 40th anniversary of the initial descriptions of AIDS. And I thought if we're going to talk about the current global state of HIV, we have to go back in time to actually look at how it's evolved and where it might be going in the future. So here are my objectives. I'm just going to move this. So first, we'll review the evolution of the HIV pandemic over the past 4 decades. Update the current global, national, and local epidemiology of HIV. Review both the national and international responses in efforts to control the spread of HIV. The target area now is 2030, so we're 8 years from that perspective. And to discuss the development and implementation of strategies for HIV infection and prevention. I have no, the federal employees, I have no conflicts of interest or disclosures to report. So let's pretend to be a time traveler today and go back in time to June 5th, 1981. What's interesting about that date for me was that it was when I moved to Johns Hopkins and was greeted with this MMWR that John Bartlett shared with me as I arrived. And it described this unusual outbreak of pneumocystis pneumonia in gay men living in Los Angeles. It was 5 individuals, sort of just incidental reporting, but it was unusual because they were previously healthy. And why were they coming down with an opportunistic infection like this? Well, 1 month later, on July 3rd of the same year, a follow-up report came out on Kaposi sarcoma and pneumocystis once again, but now it's in 26 gay men living in California and New York. So it was clear at that point something was going on. It was affecting homosexual men. We didn't have a name for it. We didn't have a cause, but the investigations were initiated and the studies were ongoing. So fast forward 1 year, so July 9th, 1982, the same infections and cancer, Kaposi sarcoma, are starting to be described in Haitians who had immigrated to the United States. So it wasn't quite certain that this was going to remain limited to just homosexual men. July 16th, just again, 2 weeks later, we see it being described in hemophiliacs, and then 6 months later in transfusion recipients, and onward, unexplained immunodeficiency and opportunistic infections in infants. And by the beginning of 1983, it's starting to look a little bit like this could emerge in heterosexuals, female sex partners of men, although there was a debate over injecting drug use at the same time for those women. Well, I was intrigued by the outbreak in the Haitians. And so I went to Haiti at the invitation of colleagues there. And it was clear that there was heterosexual transmission going on. But as we investigated it, we found that many of them had been in Africa, and simultaneously in Europe, there was a description of Africans who had immigrated to Europe coming down with AIDS. And Peter Piot and I, who had done our fellowship together, had made contact, and we did a trip to Kinshasa, Zaire, now the Democratic Republic of the Congo. We did a small study over a 1-month period, but it was clear that there was a new pattern going on from what was described in the US. And again, we still didn't know the cause at the time, but clearly it was heterosexual transmission. It had been named AIDS, and Luc Montagnier and his colleagues at the Pasteur Institute had identified a retrovirus, which they called lymphadenopathy-associated retrovirus, or LAV for short. And so we took our specimens and we sent them up to the Pasteur Institute at the end of 1983, actually. And lo and behold, all the people that we had identified as potential AIDS cases were positive for antibodies to this unusual, newly described virus. Well, most of you know the rest of that history. Sorry? Most of you know the rest of the history. Projet SIDA was initiated. That was based in Kinshasa. We hired Jonathan Mann to run that, an extraordinary epidemiologist. And we did a series of studies, and by 1986 had compiled all those studies into one report. And it was clear at the time that this was expanding, not just in the US, but throughout all of Africa. And that if prevention and control of HIV had to be an immediate priority for all African countries, or we're going to be faced with a massive pandemic, the likes that we had never seen before. And in fact, back to the US, you remember those initial descriptions were in 1981 and 82. This is the fatality rate of those people infected with that same virus, which was renamed in 86 to HIV. And this is for men aged 25 to 44 years of age. It became the #1 cause of fatalities in the United States. I interposed this photograph. Some of you remember this, where we memorialized those individuals who had died from AIDS with the laying of these AIDS quilts that covered the entire mall in Washington, D.C., from the Capitol to the Washington Monument. A truly unbelievable sight, but encapsulated the extreme death rate from this disease in those first 10 years of the pandemic. So a little bit fast forwarding to now, that pandemic resulted in essentially close to 80 million infected people since 1981. And 36 million people died from the consequences of HIV. And to really summarize what we're talking about, this is at the end of 2020, the beginning of 2021. UNAIDS, which tries to track the disease, estimated that at that time, 37.7 million people were living with HIV. That's an important number to remember as we go forward. And in the year of 2020, 1.5 million people became newly infected. And unfortunately, despite the abundance of antiretroviral drugs, there were still 680,000 deaths in that 1 year. So what does it look like globally on a daily basis? We estimate from those numbers that 4,000 people become newly infected every day. 60% of those new infections are still in the hardest hit area of sub-Saharan Africa. 10% still occur in children under 15 years of age. And 90% are among adults age 15 years or older. Half of those are women. A third of them are young people between 15 to 24 years of age. And unfortunately, 1 out of 5 are among young women ages 15 to 24. Let me back up there. I skipped one. So we talk about key populations. This is a global picture, and it's going to vary by country. And actually, we're going to go into regional descriptions of this. But if we just look at this globally, the epidemic started among men who have sex with men. Globally, they still make up somewhere between 1 out of 5 to 1 out of 4 newly infected individuals. People who inject drugs make up 9%, sex workers 11%, and the clients of sex workers and the sex partners of all of these key populations make up 20%, and transgender people 2%, which leaves about 1 out of 3 newly infected people being more encompassed in a general population, not having these types of risk factors, many of them being sexual partners of other individuals who had become HIV infected. So these are the key populations, and we'll come back to that in a bit. But as I look at this historical pattern of how we got to where we are, I look at the first 20 years and what we did to try and control HIV during those first 20 years. And it's pretty actually dismal. We tried our best. It was all based on HIV testing. And if you're positive, you got counseled, know your status. We screened the blood supply starting in 1985. It took us 4 years to get to that point. Education, behavioral modification, the use of condoms, needle exchange programs in some areas, but not universal, and an attempt to control sexually transmitted infections, but that never really took off, nor was it embraced in all countries. But this is what we dealt with for 20 years, and it sort of explains how we got to where we are today in the situation. We're all living through COVID now and Omicron and what is going on. The president gets on, says you all get a diagnostic test someday. What happened with AIDS is the administration did not want to embrace this disease, but there was a Surgeon General, C. Everett Koop, who really did try to reach out to all Americans. And on your right, Understanding AIDS was a pamphlet that they put together, and it was mailed to every single household in the United States. That was going against the administration's advice, but nevertheless, it was endorsed by the public health agencies of our country at the time. But it was trying to address the fear and stigma that was going on associated with this disease. Well, things change, thankfully, due to advances in science. And it really started with the discovery of HIV and then dissecting its life cycle. These are just a couple of the steps in the life cycle of HIV. And as they were unraveled scientifically, pharmacologically, drugs were developed that could inhibit or interfere with each of these steps of the virus. And the net effect over about a decade of that development, taking us from that 1981 to 1996, was that we started doing phase 1, phase 2 trials of these new drugs. Some of you might remember the landmark study of AZT monotherapy or zidovudine, which lowered viral load by half a log. I mean, we were ecstatic at that. But it only lasted for about 1 year and it rebounded due to resistance. So it was clear we needed 2 drugs, and that happened in the early 90s. And there was a little bit more of a durable response, but as you can see, resistance started developing. And so the movement was to 3-drug therapy, which really forms the basis of our current regimens of today, because we really did get to see durable response. Now, I saw Bob Silicano and Janet are on the line, and they talked about the reservoir, and that this type of treatment, while it was going to result in life-saving treatment, was not going to eradicate the virus. And that's been covered by Bob eloquently just last month. But what did these drugs do in terms of that fatality rate? If we just look at the US, I told you it was rising to be the beginning of the leading cause of death from 81 all the way through till 93, 95. And then that 3-drug regimen goes to work in the United States and in Europe and the rich countries of the world. And you can see the dramatic effects that it had on fatalities. And fortunately, that continues to today. And this, I always love to show this graphic because it shows how there was an enormous response therapeutically to dealing with this disease. Took a long time, but after 40 years, this is our therapeutic regimens that are available to us. All of you have probably dealt with 1 or 2 of these drugs with your patients. And I remember the day when we had to prescribe nearly 20 pills a day. And there was all this GI discomfort. You couldn't take it with food. You couldn't do this and that. Now, fast forwarding to today, we have 13 single tablet, once a day antiretroviral regimens approved in the US, many of which, once again, you're all using. But talk about advances. It took a long time, but now once a day therapy can control the virus and prevent the progression to opportunistic infections and so forth. Last year, because we're trying to update everything, the FDA approved the very first extended release injectable drug, and that's Cabenuva, which is given once every 4 weeks as an injection. What's of interest is studies have been done and have been presented to the FDA to give that injection once every 8 weeks. And we're awaiting formal review and approval of that regimen. That's going to continue. And I want to give a shout out to Charlie Flexner in this article, which really puts together all the major advances in the past year and where we are today in terms of the global therapy of long-acting formulations. You know, we can treat this once a day, but people often stop taking it or it's intermittent for them. And so the movement has been to try and get a once a month oral treatment or even longer regimens that will give us better adherence over time. For those of you who want to be brought up to date, Charlie did give medical grand rounds on some of this, and this is his paper. But again, trying to summarize the global situation, back in the 80s when I first started with this, usually once we made a diagnosis of AIDS, the lifespan was about 1 year, and sometimes even less for that. But once we got to the mid-90s, that all changed. And now today, with once a day therapy or injectables at once a month, a 20-year-old being newly diagnosed with HIV, if adherent to his or her medications, can expect a normal lifespan. There are some exceptions to that normal lifespan due to the comorbidities that are often seen in these individuals, and also due to the problems with adherence over that many years. Now, I started out with our investigations in Africa, and I wanted to come back to that because in year 2000, I visited Kampala and was just astounded by the lack of therapy that was available for any infected individual. Once again, these people on your left were waiting, hopefully, for a dose of any particular antibiotic, but certainly not an antiretroviral. So there was a concern about inequities. The rich countries doing well with this pandemic, but the poor countries doing poorly. And so that made its way to the United Nations Security Council. The first time an infectious disease has ever been actively debated and resolved unanimously to unite together to fight this particular disease. There's only been one other disease subsequently, and not as hotly debated, and that is SARS-CoV-2 infections, which just recently made it into the Security Council, and it had to do about vaccine access. But nevertheless, AIDS sort of broke that barrier. And due to those resolutions, the Global Fund on AIDS, Tuberculosis, and Malaria was launched, and the rich countries contributed to it. But simultaneously, there was bilateral assistance being made, and President Bush at the time actually came up with his advisors to launch a program called PEPFAR. And that was launched in 2003, and we're now in its fourth iteration. But the initial goals are shown here to treat 2 million infected people. It had lofty ideals and goals, but nevertheless, it started something that has continued today. And thankfully, we went from less than 1 million people a year being treated with antiretroviral drugs all the way up to now 28.2 million people on antiretroviral drugs. That is the number that you should remember. Now, we had aimed for 30 million by 2020, but we essentially got pretty close to that particular goal. The fatality rate as a result of this scale up of antiretroviral drugs, the fatality rate dropped very nicely as more and more people got treated. The sort of depressing part on this graph, and this is a very optimistic graph, is that it's leveled off. And we're going to have to work harder, and I'll give you some of the ideals that UNAIDS and others have come up with to try and get that to go down even more. Here are the global AIDS-related deaths. This was 2020 to get the death rate down closer to 500,000. But as you remember in one of my earlier slides, it was 650,000. Close, but no cigar on that. But we need to get it below 200,000 within the next 3 years. So a lot of work in terms of targeting, and we'll just have to see how that all plays out. Now, you all know about the care continuum. I don't need to tell this group, and we're going to go through this fairly quickly because, again, you all practice it. So where are we from a global perspective? And we'll get to our own country. So right now, as you heard, at the end of 2020, although we're up to 28.3 million people in therapy, back at the end of 2020, it's 27.5 million people, which leaves us with a treatment gap of 10 million people. So that's who we have to reach out to. And that number will continue to grow, as you can imagine. Why does that number pose a challenge or a barrier? Part of that's retention and care in some of the middle and low income countries. This is one study that was recently published a couple of years ago looking at the percent of patients retained. This isn't the US, this is looking in developing countries. And you can see there is a drop off of nearly 40% after 4 years. So that's one of the challenges. And so in order to address that and that gap, UNAIDS said by 2020, every single country should be at the 90-90-90. You all know what that stands for. We should get down to less than 500 new infections. You just saw we were well over 1 million, and zero discrimination. And we know that has not happened. But the guidelines have changed. And actually it says by 2030, but UNAIDS really wants this to be 2025, that we reach 95 targets. So 95% of the population should know their HIV status. 95% of those that are infected should be in care. And of those in care, 95% should be virally suppressed. If we could attain that, that would lower through the models down to 200,000 new infections among adults. And once again, the zero discrimination. So how are we really doing? And again, this is the global cascade. We'll come back to our own country in a bit. Here are the number of people living with HIV. I gave you those numbers up to the over 37 million. If you look at by 2020, we were supposed to be at the first 90, and we didn't make it. 2.3 million people still do not know their HIV status. If we now use the new goal, reaching 95% of the people who should know their HIV status, then you add those numbers and to attain them. Where are we now? About 85% or 16% of the HIV population do not know their HIV status globally. This is taking all countries. The second is how many have made it into therapy. And that's right now it's estimated at 73% of the total number have made it into therapy. And we have quite a ways to go, as we just mentioned, that gap of nearly 10 million people that need to be treated. And how many are virally suppressed? So for the globe, it's 66%, or 2 out of 3 infected people are virally suppressed. So you can see the problem with prevention and the mortality rates if we don't get that number much higher. So I mentioned the first 2 decades of prevention. I want to get to the next 2 decades and combine those treatment concerns and to the prevention concerns. And what happened over the last 20 years is we shifted, some say too much, but maybe the balance is there now, that we went from behavioral all over to biomedical. Hopefully we'll keep them in equity for the way forward. But as you know, treatment as prevention has become the norm. There are other interventions that we will talk briefly about, but we won't be able to go into great detail. Now, this thing about treatment as prevention, and sorry to re-show this particular graphic, but it was at the end or the beginning of the 21st century that we did viral loads on everyone, and we looked at transmissions in Uganda, and we found in 415 discordant couples that viral load was the most important predictor of transmission. And if you could lower that viral load, as shown here in all subjects, whether it's male to female or female to male, if you got it down to undetectable levels, there were no transmissions. In fact, we didn't see transmissions getting below 1,500 copies. Well, that was, an observational study, but you really have to do a controlled trial to actually prove that. And Mike Cohen and the HPTN really undertook a mammoth study called HPTN 052. And again, all of us refer to this. The sad part, and Mike will agree with me on this, it took 10 years from that observational study to finally get to a report that actually shows if you treat people and you get them to be virally suppressed, you reduce HIV transmission, independent of the CD4 count. So a 96% reduction. They then updated that particular study, following them for 5 more years. And again, 0 linked infections when HIV was stably suppressed by ART in the HIV infected partner. That wasn't those were the controlled trials. Then there were some others. More observational studies. One's the partner study, another one opposites attract, and the third one being the partner 2 study. You can see I bring them all up to 2019, 2020. These studies, to summarize, had no linked HIV transmissions at all in individuals that were stably suppressed by antiretroviral drugs, looking at their partners, and that's with greater than 150,000 acts of condomless sex. So if transmission is going to occur, it would occur with that type of exposure unless they're virally suppressed. So that all resulted in undetectable equals untransmissible, or U equals U. And so now we can take those treatment regimens that we were talking about, how many people are treated, how many are virally suppressed, that treatment cascade, and extrapolate back to the number of new infections globally for the last 10 years. And you can see it is declining. Unfortunately, it was only 3% annually since 2010. So if we're to meet those other targets, we have a long ways to go in terms of viral suppression and resulting in decreased transmission. Now, you know, I've been showing the global patterns, and that's probably not fair because each region has different patterns. So here is the global patterns. Looking at changes in HIV infections and AIDS deaths by region, 2010 out to 2020, and they're in the declines. So the darker bars are new infections, fatalities in the lighter bars. And so this shows over a decade, we have been reducing infections over a 10 years. So this is added over a 10-year period. It was 3% decline annually, but that is cumulative, so it was negative 31%. And here's Asia and the Pacific, the Caribbean, Eastern and Southern Africa, really showing the best declines of all, probably because of PEPFAR and the resources that have come to bear on it. Latin America, Middle East, Western, Central Africa, and North America. So you can see each region has different patterns, but there's one that's a standout, and that's Eastern Europe. That's affecting all those global numbers that I've been giving you. So I know this is a busy slide. I apologize for it, but I want you to see how the data comes together globally and by region. So let's go to Eastern Europe. Here is the number of new infections that have occurred over a 2-decade period. And it's not declining. If anything, it's increased by 43%. Actually, that's since 2010, although the graph is showing it from year 2000. And you can see again, the key population groups who are getting infected, most of them injecting drug users because there is no needle exchange programs in this region of the world. And then you can see the number of AIDS fatalities. Why is that? Because people don't come forward with their HIV status because it could mean imprisonment And so AIDS fatalities are going up. Their AIDS cascade, the treatment cascade, is miserable. Only 50% of their infected population are virally suppressed. Contrast that to sub-Saharan Africa, where PEPFAR goes. All the countries have endorsed this. And we now see the complete opposite. A 43% decline, not increase, but decline in new infections. AIDS fatalities declining by 50%. This is a really big success story. The key population groups are less defined. It's mostly in the general heterosexual population. But if we look at what was a miserable situation in year 2000 is now a very good situation that is the envy of places like Eastern Europe. 70% of their population of HIV infected people are now virally suppressed. So we are making great advances. These, I'm just going to give you quick snapshots for sake of time. Here's Asia and the Pacific. Australia contributing the most, and New Zealand the most to these declines in new infections and AIDS fatalities. Other countries not as strong, but thankfully with Australia and New Zealand's advances in PrEP, we've been able to see a lowering in the rates of infection. Latin America is in a holding pattern. You can see they're only at 60% virally suppressed. And as a result, the numbers of new infections are not really declining. So Latin America has their work cut out for it. Western Europe and North America, you can see better than South Africa, sub-Saharan Africa, but you can see we're getting viral suppression. This is including all the European countries and Canada to 74%. That's decreasing AIDS fatalities, but we're not doing as well in terms of declines of infections. Once again, the key risk groups are men who have sex with men in that region. That brings us to the United States. Let's go through our numbers. 1.2 million people living with HIV. Still, the number keeps going on, 13% unaware of their infection. 760,000 people have died since the beginning of the epidemic, 35,000 newly diagnosed in 2019. That's what CDC hasn't updated it for 2020 yet that I've seen. And we have our own disparities, as we do for COVID, we do for HIV, and they follow the same general patterns for African Americans and Hispanics in terms of racial disparities of this disease. This graphic is very, I think, very depressing. I could have done it from 2010, but just look at the last 5 years. It really is declining very, very slowly. And you'll see that again, the risk groups are men who have sex with men. Heterosexual contact makes up about 23%. Injecting drug use has markedly declined over the years. But again, it's MSM who we really have to reach out to. And so you all know 2019 and officially by 2020, we launched the new initiative to end AIDS by 2030. And it basically is on these two pillars: treatment as prevention and pre-exposure prophylaxis. We're supposed to reduce the number of new infections by 75% and a 90% reduction by 2030. So let's graph that out for you. Look at this. This is, here's our challenge. I mean, if in fact 2019 we had 34,800 new infections, by 2030 we're to be down to 3,000. It's feasible, but we're going to have to work a whole lot harder because I suspect we have not really changed this paradigm very much over the last 2 years. And we can blame COVID for some of that, but by and large, we have to do more to control this disease. So I mentioned the two main pillars. So I'm going to add a third in here, and that's more HIV testing to get to these two. So everyone should be tested for HIV all the time. I feel very strongly about that. And if they're positive, prompt linkage to care and immediate start of antiretroviral drugs. So again, these data come from CDC. I've tried to update them a little bit. Again, 86% of the HIV infected population know their status, but that leaves 13 to 14% not knowing it. About 80% that get diagnosed with HIV do get linked into care. But then there's a drop off with receipt of care, retained in care, and then ultimately viral suppression. That's for the country as a whole. But the most recent data, and I thank Jean Curley for giving me this data, is that about 59–60% of the HIV infected population of the country is virally suppressed. But if you're in the Ryan White program and you have a very good care center, and thank goodness that we have that here at Johns Hopkins, you're closer to a 90% viral suppression rate, which is what all the countries should be attaining. But it's the comprehensive care program that Ryan White provides for all these people that's enabling this higher viral suppression. Now, we've been working in the Hopkins emergency room actually since 1985, doing anonymous surveys of blinded surveys of waste blood. So it's not linked to patients' identities. But nevertheless, this was the HIV prevalence when we first started out, over 5%, hit 6% by 1988 of all comers to the Hopkins emergency room. Got as high up as 11.5%. So 1 out of 10 people coming into the emergency room being positive. But then it starts to go down. It goes down because people are getting into care and are not end up knowing their HIV status, get into care, and are not presenting with acute problems of HIV. So we applied the care cascade to these individuals in the emergency department. And it reflects some of the Baltimore City kinetics. And since we've identified all the people that are positive through this blinded survey, then we look to see, did they have a history of knowing their diagnosis? And 90% of them do in the most recent survey of 2020. But if we go back to how many are on care, the numbers are not quite as high as I would like to see them. And their viral suppression rate looks to be about the same. So this is not the Moore Clinic. This is not necessarily your patient. This is inner city Baltimore, people who are coming to the emergency department, showing this 79% viral suppression rate. Now, compared back to 2007, that's really good. It was only 32% back then. So we have made advances. We just need to get that going further. So what are the challenges at this point for getting those care cascades? Basically, you saw that nationally HIV incidence is unchanged. Current federal and state laws and regulations have given us significant structural barriers. Needle exchange programs are a good example of that. The insurance coverage is a mess for both treatment and PrEP, and my hat's off to all of you who deal with that on a daily basis. Insufficient numbers and distribution of medical providers throughout the country. Stigma is still a problem. And so we have to ask the question, what do we need to do different to contain that? And probably one of the most important is we have to confront the inequalities that AIDS has continually presented to us. The World AIDS Day of 2021, this was the theme, and I just blew it up to show it once again. The other part of the continuum here is prevention. And again, we don't have time, we're getting near the end, but I thought I'd highlight a few of these. First and foremost, PrEP works as long as you take it. And nearly all the studies show it's 99% effective if you take it on a regular basis. And this is a compilation of all the studies out there looking at detectable drug levels. So if you're not adherent, you're not going to have much in way of detectable blood drug levels of the PrEP. But those that are more adherent are going to have higher efficacy. So that's the good news. The bad news is we're not really scaling up PrEP like we did ARVs for treatment. Basically, 85 countries now have PrEP programs. UNAIDS says the target is we should be giving PrEP to 3 million people globally. Where are we? 1.3 million. So only 1 out of 3 high-risk individuals are really receiving PrEP. And if we look at the US, we're no different. Only 200,000 people were prescribed PrEP in 2018. It actually went down in 2020 because of COVID. The PrEP gap then is about 1 million people. And the sad part comes back to those inequalities and disparities. The people that are coming back that are at greatest risk, if you look at it by racial or ethnicity, are African Americans, Hispanics, and yet who's getting the PrEP? It's the Caucasians. So we really have our work cut out. And studies in MSM are showing a PrEP drop-off of 1/3 to 2/3 within 6 to 12 months. It's worse in young, people of color, women, and rural settings. In sub-Saharan Africa, there's a study called POWER, giving PrEP to women, and only 31% actually came back at 1 month for a refill. So we really have our obstacles there. And so there's been a real push to try and make PrEP more acceptable to all at-risk individuals. It can't be one size fits all. Some just don't want to take that oral pill. Some might want to prefer a vaginal ring, which works, or an implant, or other types of interventions. And in fact, we talked about cabotegravir being given for treatment, and thanks to HPTN 083, the results of that showed it's highly effective in a once-a-month injection in preventing HIV acquisition, actually better than oral therapy. And implants containing islatravir are being studied. This is just a phase 1, but an implant could last up to 1 year, and maybe that will work. And lastly, combination prevention. So we talked about treatment as prevention, and we talk about PrEP, but there's many other aspects to that. And I always give a shout out to my colleague, Kate Grabowski, and our RACI investigators. They basically showed over, a 15-year period in the RACI communities, a 42% reduction in HIV incidence through combination interventions. This is the HIV incidence. Here it is, showing as we scaled up male circumcision and antiretroviral drugs, and now we're scaling up PrEP, we're seeing declines in HIV incidence, and obviously continued declines in fatalities. And a shout out to Larry Chang, Steve Reynolds, Joseph Kagai, and again, this is in fishing villages, very high incidence, 4% in August of 2012. With that scale up, they got it down to 1.5%. That's again, a 60% reduction in HIV incidence. So where is the future of HIV prevention going? We need products that work, people that want them and will use them continually. The high effectiveness of oral PrEP indicates people can identify their risk, but we have to give better messaging, positive, engaging, lack of stigma. Delivery needs to be simple and accessible. And you will see in the next few years increasing options and formulations to come along. A couple closing thoughts is when we talk about 2022, we have to think about all the other challenges and obstacles to actually promoting all these ideals of HIV control. And I wanted to just expose these two photos. I showed you the AIDS quilt. This is the COVID fatalities for our country on the mall. That was done just in 2021 when we hit astronomical fatalities. Obviously, these two pandemics are intercolliding. They're having their effects. This is a special analysis from UNAIDS, just showing that the percent change in the number of HIV people being put on antiretroviral drugs actually declined significantly in the early part of 2020. It started to come back 2021, started to decline again. We need to be back up to pre-pandemic levels, unfortunately. And the same, you probably have experienced HIV tests performed, and this is in Fenway Health, actually declined in 2020. PrEP care also started to decline. And you know, COVID is at the top of our list, but let's face it, over the last decade, we've had to deal with all these other pandemics. I mean, you remember the Zika days, the chikungunya days, in the Middle East, MERS, dengue, and AIDS has to, our efforts to control it and to limit its transmission has to be dealt with, even though we have these other pandemics. And, you know, global health is always on my list, and there's lots of other obstacles that are posed when we talk about the obstacles to controlling AIDS. So last slide, finally. Here is, you know, my vision for the future. We have to do continued improvements in the safety and potency of ART. I know our list is fantastic, but maybe we need better, longer acting regimens that will be durable for viral suppression. Continue safe injection practices in Eastern Europe, please, and voluntary male circumcision continues in sub-Saharan Africa. We need to implement a range of effective, safe, and approachable combination prevention strategies. We now have to keep PrEP on the top of that list, or we'll never succeed. And we have to keep working towards an AIDS vaccine. You know, COVID vaccination has given us lots of optimism. Stay tuned. There's lots of other formats for an HIV vaccine. We'll have to see. I threw in the cure because Bob Silicano did such a great description of that last month. And with all these tools implemented at scale, then we can durably reduce HIV incidence domestically and globally. So let me stop there. Thank you all for your attention and applaud you for all your efforts for what you do every day in the care of HIV infected people. Thanks.
Well, Tom, that was amazing as expected. Thank you so much for this presentation. It will be recorded and available for people to go back and look at the things that you've said, and lots of kudos for you in the chat, and thank you so much. So everyone, the course will continue on January 28th when we'll have Gitanjali sorry. We're having Gail Birkenblit and a lecture on the primary care update in patients with HIV, and also a separate update on geriatric care of geriatric patients with HIV. So thanks so much to Dr. Quinn, and have a great day, everyone.
Thanks, Eileen.